methodology of how certain interventions have become second nature. Like there are many interventions which are adopted as with blind eyes. We know this has to be done, this will be done. So how certain interventions came to be in practice, this would be the first thing. Second thing, whenever new evidence surfaces, if it's challenging the prevailing practice, how to adopt it, how to give value to the new evidence. Do we change our practice? That would be the part two of how we evolve this discussion. So what we have done so far is a pair of two studies, one a landmark study, two a practice changing study. Both we will evaluate on a structure of critical appraisal. This is what Dr. Yusuf will do. Dr. Yusuf embarked on this exercise a couple of days ago, and we have managed to appraise 8 studies so far. 2 of such studies he will present now, and I will just add skeletal information for whatever he's presenting, so that it would be useful for us to uh, think in this direction whenever we are following any intervention. Today, we are planning, how we have planned these is we have chosen studies which have been remarkable for what we have encountered in the vicinity. Like the last few days, we happen to use meropenem for ESBL UTI, and how that choice is made, how stewardship direction in this particular choice. This would be first one. I think he has put bowel management as a first one. This was supposedly the second one, but anyway, we'll go both directions. So the second one is bowel management. We have encountered recurrent UTI from different ages. This has been our last month's admission, more than one or two. What is the plan for recurrent UTI as regards management? How do you, in older children specifically, above 5, if you encounter VUR, how do you go about it? And this would be part 2. So, Yusuf, it's your turn. Please go ahead.
Okay. Hello, everyone. My name is Yusuf. I'm Pediatric R1 in KHMH. We'll be discussing the studies as Dr. Vanita explained. First one is the Merino trial. It's essentially if we have an ESBL bloodstream infection and the blood culture shows that it's susceptible to both peptazo and meropenem, which antibiotic to use? Okay, so let's paint the picture first. We have an 8-year-old who's admitted with a UTI source of a bloodstream infection, and the culture results show that it's E. coli ESBL resistant to ceftriaxone. And now you have the 2 options, patients already started on empirical therapy and they're improving. So now you want to do the switch. Which one would you choose? So you ask yourself this question. So they've done this trial.
To just clarify, this is a culture grown in urine or blood?
This one in the blood.
Okay. That's the distinction you have to make. We are talking about sepsis. If it's only urinary tract infection with the said organism, the treatment choices will become different. We'll summarize it later. So we're talking about E. coli ESBL sepsis. Okay?
Yes.
Okay.
So essentially, this trial tried to prove that carbapenem-sparing antibiotic was not meaningfully worse than a carbapenem for resistant bloodstream infection. But they found that the mortality rate was 3 times higher, and the trial was or needed to be stopped early due to the high mortality. We'll go through it in the presentation. So the population they used it was on adults actually with bloodstream infections that are E. coli or Klebsiella but are resistant to ceftriaxone. They chose 391 patients from 26 hospitals in 9 countries. The countries are, second, it is Australia, New Zealand, Singapore, Italy, Turkey, Lebanon, South Africa, Saudi Arabia, and Canada. The intervention was peptazo, 4.5 gram IV every 6 hours, which is the carbapenem sparing option. It was being compared to meropenem, 1 gram IV every 8 hours as standard. So the outcome, we had a primary outcome and a secondary outcome. The primary was the all-cause mortality at 30 days. The non-inferiority margin is at 5%. This is important. I'll explain it in a bit. And the secondary outcome is the clinical or microbiologic resolution. So essentially, it's whether cultures come back as normal after the treatment is given. The non-inferiority trial,
So,
which
one sec, Dr. Yusuf, while you're doing, I'll parallelly join the discussion. Okay. So, essentially, the root uh, analysis of any critical appraisal begins with PICO. You will have to break down a study in this format that he has done. Very beautifully done. You need to know what's the population, we need to know what's the intervention, and comparator. This is a randomized control trial. He will probably add a bit about randomization, but that's the one which takes away the chance by which you are assuming things. So to give the value of the intervention, it is compared. So this is the randomized compared study skeleton. So the population, although it's an adult, since it's antibiotic and the disease, not just the antibiotic, not just the adult population, that's the concern here. It can be generalized to our population because it's the microbe also and the infection also. So the microbe, infection, these all fit into the population choice and the outcome. So you'll have to break it down if it's of your relevance and if it can be generalized, can be gathered from this. Okay, next step. Did I break your flow?
and no, someone came in the room. So this trial is called a non-inferiority trial, which essentially means that most trials try to show that a new drug is better. But this trial tried to show that peptazo is not meaningfully worse than meropenem. That means the non-inferiority design. So they assume a margin in the beginning and then they try to compare. So in this study, they pre-specified a 5% margin. So if the peptazo was the mortality rate was within 5% points below the meropenem, or essentially 5% worse, then they'd call it good enough, which is the non-inferior. So then they would accept it as a meaningful intervention. If it falls below that, or it's the mortality rate is the difference is more than 5%, it wasn't a non-inferiority anymore. It was actually inferiority. So it wouldn't be good enough to use. So this one is the methodology. So the design, as we said, it's international multi-center randomized control trial, non-inferiority, as we explained. The randomization was it was good actually. They used RedCap, which is I think a computer software to assume uh, the best or to give the best source of randomization. It was 1-to-1 permuted blocks of 2 to 4 and stratified by site, species, salt severity. This is all to say that it was properly randomized. It was the blinding, they did as much blinding as they can. It was open label. Since the outcome is mortality, it's objective, it's not subjective. So it's not like a form that someone can fill out and that can conform to biases. The only question is patient is alive or not. So that would eliminate any sort of blinding of the outcome or a bias. The non-inferiority margin we spoke about earlier, they chose 5%. The population they chose, 391 were randomized, but they assessed the 379, or the 378 of them. The sample size target, they needed 454 for 80%, but they had to stop early due to the high mortality rate or the high difference between them.
Yes, if I can add now, the sample size gives value to your study. Sample size says the powering of the study. So if that will be calculated based on a number, and if you haven't managed to reach that number, then the value of the study becomes less adaptable for practice. The second thing you were talking about, the loss of patients available till the end of the study. So your objective was to see for 30 days, and if you didn't have at the end of 30 days all the recruited participants, then there is attrition. There is your what you will do is you will take the group as how much recruited are available. So the lesser the loss, better the value of the study. So these are two factors you will keep in mind. And one more thing which I didn't see in your listing is the baseline characteristics. The 400 people recruited in group A and 400 people recruited in group B, were they all of similar severity? Were they all of, there would be some way they will map the baseline characteristics. They will say the severity scoring, probably in this, they've told Apache scoring, or uh, or the age, the comorbidity, were they all similarly distributed in both the groups? If there is a bias there, like if piptaz had more severe patients, if meropenem had less severe patients, the value of results become less useful. So you'll have to see that in critical appraisal. The baseline characteristics, this is another thing you'll have to add in your critical appraisal. I believe there was some disparity in baseline characteristics of the two groups. You can look into it later. Yeah.
Yeah. So this slide basically is a visual representation of what we just said. Yeah. So as you can see, the p-value is 0.004, which showed that there was a statistically significant difference between both, hence why they had to terminate the study earlier. And because even if they assumed the perfect scenario and extrapolated the results, they still found out that there was a difference, and it shows the non-inferior. There was no non-inferiority, so it was actually inferior. Hence why they decided to call it early.
Okay.
Yeah.
What this means is, whilst halfway through the study, from PIPTAS group, the number of patients who were dying were more, and with meropenem, although we had not reached the mark of the number of people you needed to recruit, that result was becoming apparent. Here, whenever the protocol of this many recruit has not reached, that value becomes less for the study. But here, the more important thing is ethics. If you know that PIPTAS group more are dying, you can't keep on recruiting to that group. So this ethic intervention will happen here, and that will force you to stop the trial before proceeding to your logical conclusion as you had planned in your protocol. So this was what happened. It was a dramatic difference in the mortality between the two groups. As you said, at least 5% difference was kept as a inferiority mark. Here, the difference was really going wide, and that said, you can't recruit to PIPTAS to see if this effect is real. This is very obvious that patients were dying if they were given PIPTAS. Okay, this is the clear mortality signal you're talking about. Please proceed.
Yeah, so as you can see by the graph, the PIPTAS 30-day mortality is 12.3% and the meropenem is 3.7%. There is a huge difference in the numbers. It's around 8%, and every subgroup they had from the original allocation that was randomized showed the same results, and they all favored meropenem. And so it was very clear that the PIPTAS was inferior, and as per the ethics, they had to stop. There is a twist, however, which is, I think, interesting. So that was the primary result, which was the primary outcome, which was the mortality. However, we also have a secondary outcome. What if the patient got better? What if the patient got clinically better and it showed in the consequent cultures? And this was also measured. By day 4, there was clinical and microbiologic resolution at a rate of 68.4% in PIPTAS, but 74.6% in meropenem. There was no significant difference between the both. P-value is 0.19, and the trial itself was mainly looking at the mortality. It did not address this per se, but they gave us the result. So this poses the question is, why would a drug that shows microbiologic resolution and clinical improvement still lead to more deaths as compared to the meropenem? There are a few possibilities which we can discuss later, and if anyone has the answer to that.
Okay. One thing, how do we judge if this is significant information? So there has been no significance, is what you're saying. They're both had no difference in resolution. How do we judge that? P-value. If p-value is less than 0.05, this is a conventional number, and that requires a greater discussion as to why that number was fixed. It goes to the graph and discussion later. That we will keep out of the discussion. So remember, the significance, statistical significance, is told by a p-value which is less than 0.05, which this is not. This is higher. Second thing, 95% confidence interval. this is called precision. Precision, or this is more useful clinically. Always, whenever you get a study, look into these two numbers before accepting the study as useful for yourself or your application. The p value is not giving you relevant information. Think twice. Then look into confidence interval. If it is wide, a wide confidence interval means the study is not very useful. A narrow confidence interval is more useful. Plus, it should not cross the null value, meaning one value is minus, the other one is plus. It means the range is crossing the null value, which means it's not very useful. So this particular statistical information is less significant, less precise, less clinically significant, less statistically significant. But as you said, this is one of the secondary outcome observation. Primary observation was more significant. So we can discuss about whys and whats about this later. So to summarize, you can just tell about what we gathered from this and what we should be using in our clinical practice. Can you just summarize, or you have more to tell?
The appraisal is coming up. To summarize, the outcome is mortality. It has been proven that meropenem is far more superior in reducing the mortality rate when compared to peptides, even though both of them are sensitive to the bacteria. But by the resolution of the microbiologic cultures and the clinical improvement, there is no significant difference in between both. So, is the study valid? So, we are here to assess the randomization, the blinding, and the completeness. The randomization is strong. They used the REDCap software, and they used blocks, and they stratified the patients by the site of the infection, the species, the source, and the severity. And they tried to make it as fair as possible. The blinding is they blinded as much as they can, but in the end, the clinicians and the investigators, they knew the allocation and they knew which patient was receiving what antibiotic. For the completeness or the intention to treat, I think the study is per protocol, and which means that only the sample of the patients that fall exactly per the protocol that was predetermined before starting the study were used in the study itself. So the only missing data was as they stopped earlier. So, do these results matter? There is a statistical and clinical significance, and it was an absolutely wide margin. It wasn't even a competition between both. 8.6% more, that's more than 3 times the relative risk of death. So you might ask the question, does stopping early change how we read this? Because sometimes if it's a small result, it might overestimate. There can be chances of higher or lower numbers. But no, as per the stratification and as per the per protocol population, they both pointed in the same direction, that in every subgroup, this was the result and that was the margin of difference. It wasn't by chance. And that is, as you can see by the precision. Yeah, so the discussion point is what we just discussed now. So can we apply this? Are there any limitations? We noticed that there was no US or North American data because they use a even smaller dose of peptides. So if this study was conducted in the US, who knows, the margin of difference might be even more. Does not apply to us, but it's a point worth mentioning. So they used empirical therapy at first, and that might cause some contamination. Um, the empirical therapy was the beta-lactamase or the beta-lactam inhibitors. So according to this, they argue that the bias would be towards the non-inferiority. So the actual true harm might be understated. This means that these might actually benefit, or they might help the case of the peptides rather than the meropenem. So it might even lessen the difference between both. Step-down therapy was allowed, as you can see, and the source control was unknown. We don't know if they did any other interventions that were physical or bedside interventions. Yeah. So
Okay.
yeah.
Thank you. I'll just summarize what the baseline structuring of how we go about. We see the PICO, if it's applicable to our situation. Second, we were thinking about ESBL sepsis, ESBL E. coli sepsis. This is a situation which antibiotic one most important, this is one of the landmark trials which overnight changed our antibiotic choices. Until which time, this was say 2017, I'm not mistaken. Around this time, the choice was, if both sensitive, always go for meropenem sparing or carbapenem sparing choice. But this one overnight changed the behavior. You no longer contemplate choices. You'll have to go for meropenem if it is sepsis, not plain UTI. That is the bottom line from this study. One thing we need to understand why this happens. You posed a question. It is giving sensitivity in the culture information, but why is there a wide difference in the actual evolution of resolution? One, there are two genes which are inducing resistance, which is OXA and AMC. These two genes are manifest in vivo, and these two genes are making peptides in vivo useless, although in vitro it is showing sensitivity. So this and it is not universally equal manifestations. In some they manifest more, manifest less, and this becomes the touching point in treatment decisions. So this is what happened. Meropenem, this carbapenem group, uh, have these sparing these genes which resistant genes can be negotiated by carbapenems, but these when present cannot handle peptase becomes useless in vivo. So this is the reason, and this was realized after post-hoc analysis of these cultures and such, and that's the reason why carbapenem became the choice and not contemplate even if sensitivity is shown in the blood. So first choice would be meropenem, and that became a landmark change from that year onwards. There's no debate about it because the results are staring at us saying that there's a wide difference in mortality depending on the choice you make. The point we were trying to make was make a critical appraisal, which becomes, since this is a mortality one, there is no blinding. There is something like the assessor who is assessing the outcome is blinded. He doesn't know which particular antibiotic has been given when he's assessing the outcome. As you said, this is not using a notepad and observing an outcome. This is mortality. So this blinding is not done, and it's not necessary. Since it's not done, it is called as an open label. Whenever an assessor is not blinded for outcome, it's an open label study. So open label study is said to have less value than a completely blinded, double blinded. But here, blinding is not necessary because it's not an outcome that you record or you'll manipulate. It's a death that you're uh, documenting. So overall, from the critical appraisal point, this can be applied to your situation, although we are contemplating pediatrics. Second, it is a very emphatic evidence that meropenem is better than piptas. However, when we are treating urinary tract infection, which is not sepsis, and nowadays a nuance is made between distinction of bacteremia, which is transient, and sepsis. Just presence of blood culture doesn't make it sepsis. If it's causing any organ dysfunction, that is also additionally needed to call it sepsis. Just presence of blood culture positive is not sepsis. Blood culture plus organ dysfunction, like there is a recent classification called Venus scoring that will tell you which organs you will be monitoring. There are 4 organ subtypes and it gives you a score. So this has to be there to call it a sepsis. So in a sepsis, you will have to go for a carbapenem. Nowadays, carbapenem resistance are also being documented, and that's the bottom line. Stewardship is chasing not to make it a commonplace. Whereas in UTI, you'll still have to go for carbapenem sparing options if they are available because it's not bloodstream infection. All the antibiotics which are concentrated in the urine, mostly the aminoglycosides, are more valuable than even meropenem because they achieve the MIC and concentration above MIC because they are excreted in the urine and they're accumulated in the urinary tract. So this information is for making a choice of urinary tract infection induced sepsis and not isolated urinary tract infection. That's the bottom line. So from the appraisal point, this is a well done study, and it's a landmark study because the results were very determining about practice change. We'll go for the next one. Is
Yes.
the room ready for the next one, or? Okay, you can go about it. Make a quick one. Now that we know what we are doing, so we can move on fast.
Yes. So just to conclude, for bloodstream infections that are resistant, stick with meropenem. It's the safer option. And for the rest, you can choose which one suits. Yeah, this is it. So that was the more heavier presentation. This one is a bit lighter. So bowel management plus minus standard urotherapy for pediatric bladder and bowel dysfunction. So kids with bladder and bowel dysfunction usually have both constipation and daytime wetting at the same time. They're linked because full rectum can physically and neurologically mess with the bladder function. Standard approach has always been fix the bowel first and then deal with the bladder if we need to. That was based on weak evidence. So this trial was asking the question is, what happens if we treat both at the beginning? So if we treat the bowel and the bladder from day one, do the children become better than if we just treated the bowel or not? Surprising but useful answer is no. They do the same. Adding urotherapy up front did not help, and that's the whole story. So a summary of what I just said is trial was asking whether treating the bladder and bowel together from day one beats just treating the bowel alone, and they found no difference. Bowel management alone worked just as well. Um, so you have a case, you have a 7-year-old who comes to you with wetting her clothes at school, at home, and she has a history of hard and frequent stools, occasional swelling episodes, no prior treatment for either issue. So the parents ask, should we treat constipation first, bladder first, or both right now? Yeah, I think that's a fairly common history, which we all came across in practice. So we'll start with PICO population. They chose 5 to 14-year-olds with treatment-naive bowel bladder dysfunction. Treatment-naive means they have not had any treatment for either before. Uh, and to quantify the constipation, they used a criteria, which is this one, the Rome criteria, and the daytime urinary incontinence was more than 2 episodes per week for 1 month. Um, the intervention was bowel management plus standard urotherapy. So the urotherapy was the time voiding, posture, fluid intake, and the timer watch support. And the comparison was just to bowel management alone, which was laxatives, scheduled toileting, and disinfectant regimes. So the primary outcome was wet days per week. They used a dry pie diary. So they gave the parents or the child a diary, and they were asked to note down the wet days and the severity of the wetness as well. And the secondary outcome was the stool and bladder measures. Uh, yes. So the study design was a multi-center parallel group randomized controlled trials. It was done in 5 Danish pediatric clinics in between this time period. The randomization was 1-to-1 block randomization with the stratified by sites. Again, they used the RedCap software to conceal the allocation. They couldn't do any blinding because the patients, the caregivers, the parents, outcome assessors, and the analysts were all unblinded. The duration was 12 weeks, and the outcome was assessed at 12 week or week 12 versus the baseline. And the analysis population was modified intention to treat. So some people dropped out, they couldn't finish, and it was 83 out of the 94 that met the criteria. The sample size was luckily the people who dropped out were equal in both, so we still had a almost 50-50 split. So we could compare them both together. This is what we just said. Okay, so the key findings are the expected wet days per week, which is the primary outcome. The baseline was 5.3, which was at the beginning, and then at the 12-week mark, the monotherapy, which was the bowel management alone, showed a reduction from 5.3 to 3.8, while the combination, which was adding the standard urotherapy as well, showed a similar number, almost 3.9. So there was no statistical difference in between the both of them. And they both showed almost more than or almost 50% reduction in wet days. Okay, so the difference between them was genuinely indistinguishable. Um, So this one was the kind of a twist. It was measuring the wet days. This is a post hoc, um, which means it was not part of the original compared study. They regrouped everyone afterwards, or as many as they could, and they asked them two questions. Whether the constipation is resolved or not, and then they asked them about their wet days. It was post hoc, it wasn't part of the study, but they just thought it was interesting, and they measured it. So they found out that when the children whose constipation has not resolved, the wet days per week is 4.15, while the ones with the resolved constipation was 3.44. There is a clear difference, which is statistically significant as well. However, it is post hoc, it's a non-randomized comparison. So there can only be, I mean, there can also be other factors playing. Sorry, I'm not finding the words. There can also be other factors contributing to these results. Okay.
Okay. That's summarize. You can proceed. We can summarize our applicability for. You can go ahead.
Yeah, so the randomization was strong. They used the RedCap software again. Allocation was concealed and stratified randomly, and the blinding was weak. This is because it was open label by necessity. The outcome is the diary based, and it is subjective. They had to ask the caregivers how many wet days per week or per 2 weeks, and it was as per their recollection, their memory, their adherence to the study itself. The assessors and the analysts were also unblinded. So for the completeness, or the intention to treat, they used a modified intention to treat, not a true intention to treat. Modified means those who dropped out were excluded based on the missing data, and those, yeah, that. So, do these results matter? There is no statistical or clinical difference between both. They're both improved similarly. The results were indistinguishable, and the p-value was 0.54. No statistical significance in between both. Also, this one was the trial power for this. I don't know how to explain this.
Okay. We have reached the bottom line anyways. Okay, let me just summarize. Can you just tell how the cases were selected? That will be useful for defining bowel bladder dysfunction. So that will be one thing that will be useful for our learning purposes also. Basically, to just summarize what Dr. Yusuf presented, this is a case when we encounter 5 years and above recurrent UTIs, always think of bowel bladder dysfunction to be the source. And what is bowel bladder dysfunction? It is defined clinically, it is defined by certain measures and as well as by radiological criteria. So that's how the choices were made. If the details of any study, you will choose a child to be of BBD only if these are fitting. So that's why you should know what is the definition of BBD. Anyways, let me just rush through that. That is the first exercise. Like you will choose a case by definition. Uh, Common definitions are the frequencies it is under frequent, over frequent. That is, in a day, a child passes more than 8 times. It is one of the inclusion. If the child passes less than 3 times, it's one of the inclusions. And the next objective measure is you'd see what is the estimated bladder capacity at one go, if the child passes this much or more. If the child is passing more, that means retention. Estimated bladder capacity is age plus 1 multiplied by 30. The definition goes plus 1 plus 2, but common definitions are age plus 1 multiplied by 30. Like if it's a 6-year-old, 7 by 30, 7 multiplied by 30 is 210. The estimated bladder capacity is 210. If That's why whenever you admit 48 hours, you're having the child, you'll see every time the child passes how much child passes. If the child is passing more than 210, that means the child is retaining, child is not voiding before the capacity exceeds. So this is one thing that you'll have to document. So estimated bladder capacity, and the child is passing more or less. If the child is passing very less, that means child is passing before filling of the bladder. So urgency is happening in the child. So see the frequency, 8 times and beyond, it's frequency. If estimated bladder capacity is exceeding per passing, that means child is retaining. And also, you see some measure called as post-void urine. You let the child pass urine, first check the capacity and capacity after passing. So this will give you, if anything more than 10% of estimated bladder capacity, then the child is having retained urine. So second voiding is necessary. So this is how urotherapy is designed. That is, if the child is retaining, ask her to pass more frequently. If the child is having overactive bladder, you will use relaxant. If the child is having retention, then the neck spasm is there. You sphincter spasm, you will address that. So this is how urotherapy is designed. You address what is causing it. Any of these three could be the cause, and based on that, you decide. What this study said was, apart from addressing these, more important is to address the bowel complaints. So if you relieve the constipation, they all fall in place without addressing the urotherapy. Urotherapy is addressing relaxant, addressing sphincter relaxation, or addressing detrusor instability. All these are part of treatment, but more important is bowel therapy, is what this study. This is a very recent study, and it's also very revealing and very practice-changing study. The significance may not be statistically and clinically very corroborative, but still it gave us the information to emphasize bowel care as a background intervention whenever we are dealing with recurrent UTI or bowel bladder dysfunction. So what is a bowel treatment? You will have to relieve the constipation, and proactively, even if they're not passing hard stools, uh, they should be emptying. As you said, you have this Bristol scoring, just see the hardness and just see the frequency of forwarding the bowels. This also has to be streamlined when we are treating bowel bladder dysfunction. So from this, we gathered that that is of primary importance more than addressing the urotherapy. Urotherapy probably can be secondary, and even without intervening, probably can be rectified. This is the information we have gathered. And the critical appraisal, it's a fairly useful study. It's fairly applicable to our situation. And we can apply and infer from our anecdotal experiences also. So that summarizes both the studies, and the activity was actually done good. Uh, to just summarize, this is what would be done. Do the PICO, do the randomization and blinding assessment, and intention to treat. After this, go for the precision and the clinical significance, statistical significance. Both are important. If it's a very wide clinic confidence interval, don't even go for this study. This is not really useful. If it's crossing the null line, that is, it's going from minus to plus, it's not useful. And p-value, if it is p-value is it's something everybody knows. P-value less than 0.05 is useful, but then p-value is less important than the clinical significance, which is contributed by precision. So this is how you choose the study and uh, choose the intervention for your daily practice. So do you find this activity useful? Would you go about this? I'm asking you, Dr. Yusuf. Would you go about this when you're picking studies next, whenever you are doing any intervention?
Inshallah.
Okay, thank you. And we'll go for the next set of studies. Or we'll present the older ones, but we'll go for the next set. We are already in time for the next set of studies. Thank you.
Thank you, everyone. Thanks for
If the
listening.
group wants to ask some questions, you can take the questions.
Yes.
Thank you so much. That was really valuable. We tried to understand as much as we could, but thank you so much.
Thanks.
Congratulations, Dr. Yusuf, for getting started. I think once you get started, it's like a warm up thing, it will continue. Wishing that this journal club is a regular um, feature of our monthly CMEs. I mean, every week we have a CME. So if you can fixate to one, maybe the third week, third Tuesday of every month, like what we discussed earlier, then it'll be more regularized rather than it be random. So I think you can work on that. And thank you for for this presentation. And thanks to you, Dr. Vanita, for being his mentor and inspiration.
Thank you. And we can
Thank you, Dr.
broaden the
Vanita.
scope by involving others also in the activity. Thank you
Correct.
very much.
Now, what I would also suggest is, after having gone in depth with the study, for practice purposes, what are the things that we translate directly into practice? If that can just be summarized and mentioned in 2 or 3 different points for the whole group, for all the group of pediatricians, I think that will be more useful than just finding, just presenting and then discussing the whole thing. So, in summary, if you can just take away, put up the take home points. What are the key points that we derive? What are the practice points that we have from these 2 studies? That'll be great.
Sure.
So if you could summarize those 2, I think from the first study, it is that meropenem, without any doubt, should be the choice if there is E. coli, ESBL, sepsis, bacterial sepsis, right?
Bacteremia. If it was localized infection, you can
then you can still choose. You still
Yeah.
have a meropenem sparing choice of antibiotics you could choose. But if it is sepsis, where more than one organ is affected, then you will have to know 2 things about it. You will choose meropenem. And in the second study is that although there is not much of difference between mono or combination therapy, it's better to deal with the bowel as well when you deal with UTI. Is that right?
Yes. Second study had
In bowel bladder dysfunction, now the standard is to check if it is retention or if it is sphincter dysfunction, because both have different urotherapy. More important than that would be to address the bowel. Despite doing both parallelly, this is what we follow now. You address constipation, you address, if it is retention, you address detrusor instability or sphincter. These are the 2 directions with which you proceed with urotherapy. From this study, whether you do that or not, doing just bowel care is gonna solve the recurrent UTI or the bowel bladder dysfunction. So focus on bowel care upfront. Focus on proactive bowel dysfunction management and follow through if this is still lingering, either the retention or the frequency. This is how, because urotherapy is very psychologically overwhelming. This is something which parents have to very diligently follow. You can avoid all that stress. Focus on bowel. Most of your treatment will be sorted. And if it is still lingering on one particular direction, then you can apply additional urotherapy. This is again a practice changing concept. This is what was gathered from the study. And this is what is informed for practice change also. So focus on bowel care. Uh, Go about stool softness and bowel evacuating habits change, and look at the change in the recurrences of bowel bladder dysfunction as the voiding dairy suggests. If that is already fixing your problem, you probably don't need urotherapy intervention at all. But if that's still requiring particular direction, you can add standard urotherapy to bowel. So primary bottom line care should be to address the bowel care and keep it continued.
Yeah.
Okay.
Thank you.
Thank you, everyone.
Have a good weekend, all of you who are having the
Yusuf,
weekend off.
I just want to add one thing. First thing, well done. Thank you for your critical appraisal. It was very informative. I think for the sake of simplicity for the interns, for them to better be, let's say, acquainted with how to critically appraise a research, I think it would be useful if you teach them how to use the PICO tool. Yeah, because they're at the beginning of their careers, and I'm sure they're going to do journal clubs. They might even do journal clubs soon, not necessarily during residency. So it would be great if you taught them how to use the PICO tool as a tool for critically appraising researches and basically or essentially randomized controlled trials. Because I remember when I was a resident, I had a senior resident teach me this. So I'm sure it's gonna go. I mean, it's gonna be good if you also pass down the knowledge, just like how Dr. Vanita taught you.
Yes.
So yeah, well done. Looking forward to the next journal club. Thank you.
Thank you so much.
I will pass the template on which you do the appraisal, which Dr. Yusuf is using also in the group, so that this you can send for interns also, as a couple of them have taken it from me. This would be basically what you have done. So I'll just pass the template for the group also.
Yeah.
All right. Thank you, everybody.
Thank
So
you.
we close the meeting.
Yeah. Have a good day,
You
everyone.
can have a deep sigh of relief, Dr. Yusuf, and enjoy your weekend. Bye. Well done.
Thank you. Bye.